I have the pleasure of introducing our speaker today. Dr. Rachel Haroz is an associate professor in the Department of Emergency Medicine at Cooper Medical School of Rowan University and division head of toxicology and addiction medicine. She is board certified in emergency medicine, medical toxicology, and addiction medicine. She has spent the last 17 years working in inner city emergency departments, mostly in Camden area, where opioid use is rampant. She has helped build and now staffs the outreach clinic at the Urban Health Institute at Cooper University in Camden. In 2016, she helped create and implement the initiative to describe buprenorphine from the emergency department and bridge patients to treatment to various community partners. And in 2019, she helped launch an innovative program aimed at initiating buprenorphine via paramedics in the field, which we'll hear more about today. And she is also heavily involved in education of residents, medical students, pharmacists, and organizations, and organizes education forums focused on topics related to opioid dependency and treatment. So everyone, please welcome Dr. Haroz.
And I would like to just start. I know that John just read my bio, but I do just want to take a minute and tell you guys about myself, because I want you to understand like my background and where I'm coming from, and it'll kind of put things into perspective. So I'm an ER doc by training. I've been an ER doc for a really long time. It's been 22 years at this point. And I started off as an ER doc and as a toxicologist. So, and as you probably know, the ER approach to addiction in general is always been very problematic, right? It's basically like, my entire goal is to get you out of my ED. That is, there's never in my training, especially early on, were there ever interventions aimed at identifying these patients, helping patients, actually treating their addiction. And so I didn't actually enter the field of addiction until about 7 years ago. And this mostly happened because Camden was in such a bad place, right? We just had so many overdoses. There was really no good care being provided except in one FQHC. And the healthcare community here really felt that we needed to do something. And as a toxicologist, I sort of got pulled into it. I didn't come willingly. This was not something that I didn't put my foot forward and volunteer. I was volunteered by one of my other colleagues, and out of pure guilt, I followed him into this work. That being said, I can tell you that one, this is hands down the best thing I have ever done, probably the most important work I've ever done. And two, I have been completely overwhelmed by the sheer injustice and the wrongfulness with how this entire field has been seen both by the medical community, how it's been treated, and where our focus has been. And so, as I have come to this realization, I have done what I can to try to integrate it into healthcare as much as possible, and at least in our small little area, create a model for how we can do this and how we can do this well. And so some of the things that I'm going to talk about, you'll see again, like we do, this is something we've created in Camden. And when we were creating it, we always thought about it as something that can be brought to the rest of the country. But we wanted to see how it would go first. And I also just wanted to say thank you to John, and thank you for inviting me and for allowing me to present this really important work that we have done here in Camden. So let's talk a little bit about the actual scope of the problem, right? So I was just Googling the population of Kentucky. I saw you guys have 8 or 9 counties. We have 21 counties in New Jersey. We're a really small little state with an incredibly large population. So you guys have about 4.5 million. We have almost 9 million in a much smaller space. So we are very densely populated, and we have a very large opioid problem. And I put up the 2019 deaths because that was really right around the time frame, 2018 to 2019, when we launched this program. And we had consistently every single year gone up in the percentage of deaths. And now what you can see on this table, you can see so on this map, Where the gold star is where we are. So we're down in Camden. We're right, literally a stone's throw away from Philadelphia. We actually share the drug landscape with Philadelphia. So whatever's going down in Philadelphia, whatever's happening in Kensington is also happening in Camden. We are not in the same drug landscape as New York City. We don't share sports teams and we don't really share drugs. Let's just be honest. But you can see Essex County, which is up north near Newark, has the highest number of deaths, and then very closely followed by Camden. So we very much have a very large problem. On top of that, we have about 40% of our population that lives at or below the poverty line. And the city of Camden, although fairly well known, is really only about 74,000 people. The problem is that many of the people that overdose in Camden, as a matter of fact, most of the people that overdose in Camden are not actually from Camden. They come to Camden to get their drugs. They come to Camden and they stay, but they are not, in fact, Camden residents. So I'm going to give you an example of kind of the setting in which all this kind of came to be. So, you know, let's go back to 2018 because this is when this was all sort of stirring, right? And you know, just a very typical afternoon in Camden. So our ALS, you know, gets called to the scene. Our abandoned buildings are called bandos, and we have a lot of them. And a lot of times our patients will just squat in them. So, you know, on any of the floors, a lot of times in the basement because the structures are not necessarily safe. So they'll just squat in the basement. So ALS gets called to the scene of a 24-year-old who's found unresponsive, not breathing, very clear. And the people around him are very clear. Hey, you know, he overdosed. The patient is bagged by ALS and they give him the intranasal naloxone, the 4 milligrams, and the patient responds, you know, starts to wake up, is very angry. The scene is hostile, right? Everybody there is angry at the paramedics, angry at the situation. And the paramedics notice, you know, besides the fact that it's very filthy. There's human excrement, there's vomit. They also notice that there's other bag valve masks, right? So they just bag the patient, but they notice that their own bag valve masks from a previous visit are still on the floor, and there are leftover boxes of naloxone from previous visits. And they recognize the patient. They actually recognize other people in the basement. And the patient refuses to come to the hospital. In fact, the patient is very angry with EMS for even, you know, bringing him back. And ALS ends up leaving, and they're feeling very, you know, they're very frustrated. They feel very helpless. There's really nothing they can do. They're not able to really even have an engaging conversation. And so they just sort of throw up their hands and they leave. And this is a scene that is repeated over and over again, unfortunately, in Camden at that time. And our EMS are you know, getting very burnt out. Now, at the same time, if you move just down the street, what you find is you find Cooper, and that's the institution that I work at. And we actually started building our addiction division in 2015. In fact, we opened our doors in November of 2015. Now you may say, wow, that's pretty late. And it is, I agree. We should have had an addiction division 20, 30, 50 years ago. But we didn't. And so our division was formed in November of 2015. Cooper is it's a 635 bed hospital. It's a tertiary care, level 1 trauma. It's the level 1 trauma center for all of South Jersey. So we encompass all of South Jersey, going all the way up to Trenton. We have, I think at this point, we're about 82,000 ED visits a year. And we see an incredible number of overdoses. It's not unusual for us to have 5 to 15 overdoses. There are days where we have 20 something overdoses, especially because in Camden, we have something called free sample day. And free sample day is when they give out free samples. I kid you not. And when that happens, we usually had just a lot of people go down. Some people die, but a lot of people go down and they just get brought in, and sometimes there's literally it can be up to 20 people all being brought in at various times over a very short period of time. And I actually don't know if anybody else in the country has free sample day, but we definitely have it here in Camden. We also have a very high morbidity burden on our hospitals. So just to give you an example, in one quarter of 2018, we had 64 new endocarditis cases. We have endocarditis, we have spinal abscesses, we have a lot of osteomyelitis. We have a lot of the morbidity that results in a large population that is actively using IV drugs. Now, again, in this institution, we worked very hard to build an addiction medicine division. And here's just a picture of our division. I will tell you, we started with 3 physicians, 2 of us were part-time, and 3 other staff. So there were about 5 or 6 of us. And we are now 56 individuals, including therapists, admin staff, physicians, APNs. So we have grown exponentially between 2015 and 2022, and it's all good. But you're gonna see why I'm explaining all this. So back in 2018, we're already growing exponentially. At that point, we have a 5-day-a-week clinic, which at the time we called the outreach clinic. We're now called the Center for Healing and Integrated Care. We had a perinatal program all day Tuesday. We had an inpatient consult service. We had integrated with infectious disease already. So we had an HIV and Hep C integrated clinic. We had 2 suburban and rural locations. We were planning and starting an addiction fellowship. And we were just building this incredibly robust, mission-driven program. In addition, our emergency department. So I'll be very honest. I actually called Dr. Gail D'Onofrio in 2016 because I had read her paper and I thought, oh my God, we have to be doing this in the ED. And I called her and I said, how do I do this? How do I build this in our ED? And she was really very instrumental in helping me kind of organize, structure, teach, etc. But we started prescribing back in 2016, and our chair actually mandated that our entire ED had to be waivered. It was non-negotiable. And so we, even back then, started treating withdrawal with buprenorphine and methadone, prescribing buprenorphine, referring. We had really robust partnerships with several community providers. We had 2 FQHCs, we had a OTP, and we worked very closely with them. So here we are, right? And I wrote that at the time we were bridging about 30 to 40 patients weekly. We now bridge many, many more patients, but our emergency department has remained integral. In fact, I can just tell you, we do OUD, we also do AUD. We give naltrexone, Vivitrol injections in the ED. So we have a ED that is incredibly poised to address this, right? In addition, our mission across our institution is one of harm reduction. So we focus very much on, the marker for success, not necessarily being sobriety, but the marker for success is one, achieving the patient's goals, and also a decrease in mortality and a decrease in morbidity. So if that means helping patients access syringes and alcohol swabs, making sure that their access to MAT is low barrier and unrestricted, and helping them with safe injection practices, and that's what we do. If I could, I would open a safe injection site tomorrow, but right now, we're not quite there yet, but I'm hoping that's the direction we're going in. So I'm painting this picture for you, so you have to understand that we have, on one side, we have EMS, who's out in the field interacting with these patients, and right down the street, we have this institution, right? Now, just so you can see how much naloxone was being administered at the time. This is from 2018, and this is a combination you can see in red and in blue, the combined naloxone administrations in the different counties. You can see these are our 21 counties. The one that's really high, that's Camden. And we at that year, there were just over 3,000 naloxone administrations by law enforcement and by EMS. That does not include those naloxone administrations that are bystander. I'm sure you guys have that too. We have an incredible number of bystander naloxone being administered right now because we've made such an effort to get it out there. So you can see how often EMS is encountering this in the field. So the next question is, well, great, you have EMS in the field. You have really this incredibly robust program that's created down the street. Sounds like a no-brainer. But here's where we ran into trouble, right? in the city of Camden, drug use was being decriminalized. So if you, it used to be a long time ago, 15 years ago, that if you overdosed, they basically said to you, look, you have two choices. You go to jail or you go to the ED. And so patients were like, all right, I'll go to the ED. But when it got decriminalized and the cops stopped showing up, patients just started refusing. They're like, well, I'm not going anywhere. I'm staying right here. So we can really build the best program in the world, the most robust, open-minded harm reduction program in the world. But if we're not able to get our patients to the program, then we're missing we're actually missing the most vulnerable, the most at-risk population, because they're actually still out there in the basements, in these abandoned buildings, and we're not able to interact with them. So our transport refusal rate had consistently been going up. And so at that point, it was right at 40%. And this was really just adding to our poor EMS, right? They really just felt like they were just struggling. They were burnt out. They were leaving in droves. And we had to figure out a different approach. Now, right around that time, this grant came along. Now, it was not a grant that we were seeking, but actually the CDC had taken note of the fact that our refusal rate, so we have this incredibly high overdose rate in Camden, plus we had a really high refusal rate. And so through the CDC and the state, we were offered a grant. And the grant was, it was only $250,000. And I say only $250,000 because it sounds like a lot. There's not a lot you can do with that. But we were offered $250,000 with the mission that we would send counselors out to these overdoses to talk to the patients, to convince them to come to the hospital or to seek care. And at one point, there was even a request that, well, can you just do telemedicine right on the scene? Can the patient pull out their smartphone and have a conversation with the physician on the other end? And, I think for those of us that have worked in EMS, and especially in inner city EMS, there were so many problems with that. The first thing is that these patients, first of all, they're not going to be in any mode to really have a conversation after an overdose. If you've ever seen anyone after an overdose, they're disoriented, they're vomiting, they're not feeling good. They want you out. They want, they don't have shoes. They're not going to sit and have this counseling session. That's just not going to happen. The second thing was that smartphones, many of these patients, they don't have shoes on them. They're partially dressed. To think that this patient was going to wake up from an overdose, whip out their smartphone and have an entire telesession was just, it just wasn't honestly based in reality. And we had multiple meetings about that. And ultimately what it came down to, and by the way, we did end up hiring a counselor, and she quit because even though she was quite experienced in OTP and worked in addiction, going out into the field was incredibly traumatizing for her. And she really didn't want to do it. And again, unless you come from the world of EMS and you've been there and you're experienced, it's actually really hard to go out and engage with this patient population in a meaningful way. However, that being said, we sat around a table and we brainstormed and we thought, okay, we're being offered this money. What can we do that is actually going to be meaningful, impactful, and sustainable? And so what we decided to do is we wanted to look at something that was actually grounded in evidence-based medicine. So what is out there that will make a difference and actually change morbidity and mortality? Not that there's anything wrong with counseling, it's just that the evidence behind that just really isn't there. And again, I'm not saying that it's not part of an integrated model, but it's just that providing counseling as that single intervention in the middle of the field, just it didn't feel right to us. Now, why to us was this so incredibly important, right? Like, why is this patient population in particular at such high risk? And I just put this up, and this is actually Scott Weiner's paper, and Dr. Weiner is a physician up at Mass General, and we're both ER docs, and we talk a lot about this work. But they looked at, and this is the latest paper. This is actually from 2022, but he had published about this in the past. And what they were looking at is that patient population that overdoses and receives naloxone, what kind of mortality, like how at risk, right? Because if you think about it, in medicine, that's how we look at everything. We're like, okay, well, where do we need to intervene? Who's the most acutely ill? Who has the highest mortality? And that's how we gauge our responses. And before I even talk about this any further, I'm just going to tell you that in the world of EMS, there are very few medical situations that are more acute than a ST elevation MI, so a heart attack, like an actual heart attack that you can see on your EKG, right? And I know that this audience that I'm talking to today is a little bit varied, but it's called a STEMI. And when you have a STEMI in the field and in the ER, it's like all hell breaks loose, right? It's like all these people in white coats come running down. I don't even know who they are, but they all come running down. And the reason they do that is because an ST elevation MI, this heart attack, has such a high mortality. And we know that a certain intervention, which is the cath lab, within 90 minutes, so door to balloon time being when they can get into the blood vessel and open it back up again, of less than 90 minutes, significantly decreases mortality, right? And so we have all these metrics. You identify this patient, you bring them in, you have the ER waiting, you have the cath lab waiting, et cetera, et cetera. And if you miss that, oh, there's meetings about it. Like, Dr. Haroz, you missed getting this patient to the cath lab. It's a big deal because we know that that intervention makes a difference and changes lives. Now, what's the mortality? Well, the mortality in the first month after a STEMI, it's actually somewhere about 12 to 13%. And sending it to the cath lab brings that mortality down to about 3 to 4%. But look at what I'm showing you here, right? So the mortality of patients that receive Narcan for an opioid overdose by EMS is actually 15%, right? And if you look actually here on the right, you'll see that most of them die in that first month. So they die very soon after having had that overdose. Now, you could say, well, that's nice, but you don't have a cath lab, right? What are you going to do with these patients? What do you have that is as life-saving? And the answer is we have something. We have these incredible medications, right? Medications for opioid use disorder, and they are so effective. We know that they can decrease mortality up to about 60% and 76% in the first 3 months. Remember this when I showed you this, right? So most of this happens in that first month, right? So we do have an intervention. And so that's actually what we were looking at. And again, like our institution, our addiction division, we are very much rooted in evidence-based medicine. We believe in evidence-based medicine, low barrier care. And so we looked at this, and I just want to put this up. And this is from the PCSS. And I just really love this demonstration because it just shows you that if in green you have a standardized mortality ratio for the general population of 1, and in the setting of having opioid use disorder, active opioid use disorder, if you don't provide evidence-based treatment, and when I say that, I specifically am talking about medications, right? And only 2, buprenorphine and methadone, those are the only 2 that have actually been shown to decrease mortality. Naltrexone is there and it does help with retention and treatment, but it actually has not been shown to decrease mortality. It's the first 2, it's the actual agonists. And so if you look here, if you provide everything else but those 2 medications, people still have a 6-fold increase in mortality. And then if you add those, it goes down to about 1.8. And that's incredibly powerful. And so again, whenever you're thinking of doing some sort of intervention, you want to look at where the evidence is. Now, our patient population out there, right? About 80% are not getting this pharmacotherapy. So again, putting all this together, for us, it was incredibly important that we move in the direction that hopefully would make a difference. The 3 medications, obviously, that we were looking at are buprenorphine, methadone, and naltrexone. Now, naltrexone is simply not an option in the acute setting, right? Because you do have to be sober for 7 to 10 days, and it's simply not feasible. Methadone, given all the restrictions, simply was just not gonna work. But buprenorphine, now we're talking. We already had experience in the hospital. We had experience in the ED. We also knew from several case reports and several of our colleagues that you could treat naloxone-induced withdrawal, naloxone-precipitated withdrawal with buprenorphine. It worked. Patients got better. So we started thinking of a way that we could actually do an on-the-scene intervention that would make a difference. Now, a few things about our Cooper EMS. We're fairly small. I told you the city's only 75,000 people. We have 5 ALS units and 8 BLS units. We do have 1 community medic. We have about 35,000 calls a year, of which number 1 and number 2 are unconscious and overdose. So those are really our number 1 and number 2 calls. At any given time, we have about 2 to 3 ALS units that are out, and then they're backed up by BLS units. Now, I will not lie, our EMS culture and our EMS community at that time was probably no different than other ones across the country, which meant that we knew going into it that we were going to need culture change. We were going to need to teach EMS the tools for engagement, and we needed to teach them about medications for addiction treatment, right? We knew there was going to be an educational gap. That being said, we had another big challenge, and that challenge was that the state of New Jersey may actually be the most regulated state in the entire country. And so we actually found out that EMS could not actually even give out buprenorphine. So it was not actually a medication that could be delivered by paramedics. So we had to go to the state legislature and the health commissioner and ask for a directive to be passed and to allow ALS to administer buprenorphine. And so that is what happened. And in the summer of 2019, this was passed. Now, I'll tell you a little bit about our program, but we had already started some of the piloting before this was passed, and we started with just the physicians being able to administer the buprenorphine. But luckily for us, there was an executive directive that was passed and has now been put into law that allowed us to do this. And again, I'm saying this mostly because I realized I've actually never been to Kentucky. But whatever your state laws are, you will have to work with them if you want to create something like this. Now, how did we go about actually doing this? So we, even as we were trying to get the laws passed, we started with different educational modules. First thing we did is I actually spent time with EMS. So I went to one of their meetings. I presented on opiate use disorder, with one of our therapists. I presented on the medications. I explained the evidence, and it did not go well. It did not go well at all. The response was very much, oh my God, we're going to be giving the patients with a drug problem drugs. Awesome. Absolutely not. We're not going to do that. People got very upset. They were, talked about tough love and like, what are we doing? And et cetera, et cetera. But there were some that listened and some that actually felt like this was an option, given how burnt out and helpless everyone was feeling. And so over time, we started getting some champions. We then created a webinar for everybody to watch. And then what we did is we took some of the paramedics that were willing, and we brought them into clinic. And we actually had them spend one-on-one time with the staff in clinic. And what that allowed them to do is they were able to see some of these patients who they only knew from the streets and under the bridge in a clinic setting where they were actually dressed and sober and having conversations. And they were able to ask all their questions in real time. And I can tell you that made a huge difference, because all of a sudden you had all these paramedics that were, kind of seeing, having these aha moments like, oh my God, this works. Like, this is incredible. I know this guy. Like, I remember this person. This is like, I remember them from 2 years ago. They were overdosing, etc. And also it created relationships between the addiction team and the paramedics. We had journal club. And then the other thing that we did, and we have the luxury of having an EMS fellowship. So we have an addiction fellowship, we have an EMS fellowship. And so we were able to have EMS physicians actually on scene supporting the paramedics in real time. Now, before we had the legislature, before the executive order got passed, one of the most important things that we taught EMS was engagement. And I cannot stress that enough. I'm going to stop for a second because I'm going to tell you something that I think is really important. There's a lot of work being done out there on reaching patients that are harder to reach, right? So having vans and buses and transport teams and all kinds of innovative, cool ideas of getting out there and interacting with these patients that you can't reach. But here's the thing. We already have an infrastructure that does that. We already have a trusted infrastructure. This isn't law enforcement. This is EMS. This is 911. These are the people that you call when you need help, when you have a medical problem, right? So we have an entire structure, as Mr. Rogers would say, of helpers. So our thought was, rather than inventing all these cool, innovative ideas, let's use what we have. We have an infrastructure of trained professionals. Let's teach them about this disease. Let's create a paradigm shift. Let's change the culture, and let's teach them the skills they don't have, right? So before I started doing this, I didn't know how to talk to these patients. I literally remember as a resident being like, yo, like, you need to stop using drugs. Really? Like, I think back now, like, I'm embarrassed. I mean, of course, they know that. That's not the point, right? So we worked on motivational interviewing. We demonstrated, we showed them literally how to engage with this patient population. And that literally was the entire first strategy before we were able to institute the buprenorphine. We also created an infographic sheet that basically had resources, had very kind language, and that they could hand out prior to the buprenorphine. So let's move into what we did next. Now, this may be a little bit hard to see, and I'm just going to walk you through it. This is our actual algorithm, and I'll show you in a minute. We actually published on it, and you can pull it. You'll also have access to, I'm happy to share my slides. So what did we do? Now, we, so here's our algorithm. So any patient that had an opioid overdose that received naloxone, I'm going to just stop for a minute. Our executive directive was very clear that the patient had to have received naloxone in order to receive buprenorphine. If I had to do it again, and I didn't have a lot of leeway, unfortunately, because we literally were the first to do this. And so, they were trying to have some sort of guidelines. But if I were to do it again, and I can tell you California and Texas, when they instituted this, they did not use these guidelines, but I would have it for any person that has an opiate use disorder, because you want to also be able to give it to patients that have withdrawal. But in our case, it was very clear. It had to be a patient that overdosed on an opiate and received naloxone. Now, for exclusion criteria, we used if they were not able to give their name and date of birth. I mean, they had to be awake, alert, and able to give consent to receive the buprenorphine. We only had 18 and above and non-pregnant, so we excluded pregnant, even though pregnancy is perfectly fine, and we can and should be giving this to patients on the street who are pregnant as well. They could not actively be on methadone, so they could not have received a methadone dose in the last 48 hours. And again, that was really just based on patient providing that information. And again, if they were altered or there was something else going on, like if they were hypotensive or hemodynamically unstable, et cetera. If they did not have those exclusion criteria and they had a CAL score of at least 7, I will tell you, we started with 7, but we actually went down to 3, 5, anything, because what we found is as long as you received naloxone, you could receive the buprenorphine, no problem. We then asked them whether or not they were interested in receiving the buprenorphine, especially if they had a CAL score that was slightly higher, because we knew that they would actually feel better. We made sure that the mouth was actually moist. And this became actually really important because after an overdose, what we found is a lot of our patients had very dry mouths. And so the paramedics would have to carry water bottles. And then we would give them 16 milligrams of sublingual buprenorphine. We started out with the tablets because we our hospital only carries the straight buprenorphine tablets. However, it was taking too long for them to dissolve. So we actually switched to the strips. The strips dissolve much faster. And so we administered them. We gave them 4 milligrams of ondansetron, and then they were reassessed. If they still had some symptoms, they received another 8 milligrams for a total of 24. And then they were given the option to either go to the hospital or just get an appointment. Now, a couple more things. One, the state felt very strongly that they had to check in with the physician, which was actually easy for us because Cooper is the medical command for all. We run all our own EMS service. So they could just call into the med command phone and ask for a bupe bundle, and they would just get, permission to get a bupe bundle. And a bupe bundle really was just the up to 24 milligrams of buprenorphine and the 4 milligrams of ondansetron. Now I'm just going to go, this is just kind of a much easier picture of what we were doing. And the most important part came at the end because we would, again, because we had 40% that did not want to come, we were able to give them an appointment in the spot. And usually the appointment was within 24 to 48 hours. As a matter of fact, it was always within 24 hours if it was during the week. The only problems we would run into was on the weekend, and then the ED would just dose them or give them a prescription or however they wanted to handle it. But they would leave the scene with an appointment in hand for the next day. Some were even offered same-day appointments. We were able to publish this pretty early on, just kind of as a case series. And I'm going to show you some of this data. So we offered Suboxone early on, and I use the word Suboxone specifically because it was the combo product, the strips that we did use. We offered it to over 1,000 patients. At that time, very early on, about 104 accepted. And of those, 44% made it to their first appointment. Now, I know you can look at it and say, oh, that's not a lot. But in the world of addiction, that's huge. Our ED data isn't that much better, right? So our ED data, we only have but between 40 to 60% that come from the ED. So 44% was incredible. Remember, this is our most vulnerable population. And 61 of those made it, stayed with us for the first 30 days. A lot of people ask about on-scene time, and our average on-scene time was 24 minutes, and it really only extended our on-scene time about 4 to 6 minutes. That's it. Obviously, that's a big concern, especially in areas where you may not have a lot of crews, and you don't want to stay there for an hour because you can't take those resources away from the rest of the county. But it turns out that that was not the case. In fact, it was almost, in a lot of ways, it was easier for the medics to wrap up because there was a plan. Again, 24 minutes. This was, just some more data. Our on-scene time was about 24 minutes. Of those that received buprenorphine in the field, the majority were male. Our numbers in general are more male, so we just have more men. We have more men in our clinic in general. And then of those first appointments in clinic, again, more 72% male, 28% female. The amount of naloxone that was administered, and I can tell you 76% received about 2 milligrams, the rest received more. One of the things that we have been running into more now is because so many of our bystanders have naloxone, one bystander will give 4, and then another bystander will give 4, and then another. So sometimes by the time the patient comes to us, they received 8 or 12 milligrams, none of it given by EMS, just because everybody's just so just jumps all over that patient. So, but there, back in 2018, 2019, when we first started doing this, 76% had received 2 milligrams. On average, our initial COW scoring was 9.6, and after buprenorphine administration was 3.3. So you can see that's a significant reduction. Patients felt better. Of that patient population, about 6 patients were rebridged. So they missed their appointment, overdosed again, and were rebridged. The one thing that's really important, especially in the era of precipitated withdrawal, is that no patients got worse, not one. And we actually, I don't have the data here because we're just submitting it now, but we are up to about 170 patients at this point and not one has gotten worse. They have all, in fact, gotten better. So that to us is, to me, that's safety data, because I know that there was a lot of concern. Are we going to make them worse with the buprenorphine? Are we going to precipitate them? Is it going to last and they're going to feel worse? And the answer is a resounding no. They are all getting better. Now, let's talk for a second about barriers, because we started this off and it had a huge amount of momentum, but we definitely hit some barriers. One of the biggest barriers that we had was patients were afraid of being precipitated, right? They would say, no, I'm going to get precip, even though they had just gotten naloxone. And really, if you're not precipitated by naloxone, buprenorphine isn't going to do it, but that's okay. So there was a huge fear. And there continues to be a huge fear on the street about buprenorphine precipitating withdrawal. I don't know why, but for some reason, giving patients that naloxone seems to prevent the precipitation. It just, once they've gotten naloxone and they've gotten the buprenorphine, they do not get precipitated. But that is a huge barrier. The other one was what happens when the patient doesn't have a COW score. And we actually had built that in, and I didn't show you that, but one of the things that we talked about, because we have one of the largest jails in New Jersey, actually 2 blocks from the hospital. And so sometimes patients come, and we know patients coming out of jail have a very, with OUD, have a high overdose rate. And our jail does do buprenorphine and Sublocade and is very active, but you still will get those patients that are coming out of incarceration or they're coming out of rehab and they have been sober and their tolerance is low. So, but when they get the Narcan, they don't necessarily go into withdrawal because they're not dependent, because they have been sober. And so we did build that in. So if you had patients who did not necessarily withdraw and they told you they just actually hadn't been using and this was their first use, we were able to give them the buprenorphine anyway. We, continue to have to work with on-scene time and making sure that that was not, really prolonged. One of the ways that we did try to work on it is, I showed you earlier, we have a community paramedic, and having that community paramedic show up and take over. And we're still working on that model to see how we can do that so we could relieve at least the ALS crew to go back to being active. And then finally, just provider motivation. Everybody gets very excited about a program. And then with time, sort of, kind of fades. And so again, for us, luckily, having an EMS fellowship has been incredibly helpful because we were able to put the physicians out in the field to help inspire, support, and kind of lead the charge in this realm. And again, if you're going to be doing that, I highly recommend, if you do have physicians, having the physicians go out there and work on this. Now, one of the things that was really helpful, and I acknowledge that this is something that we had that a lot of people don't usually have, and that is we had sort of a triad of support. And for us, that means we had an emergency department that was 100% waivered, actively prescribing, was never alarmed or surprised if somebody, and again, we have a lot of people that come to the ED that are like, I missed my appointment, I want to reestablish care, I lost my prescription. And our ED does whatever it takes to help people get back into care. And even if they can't necessarily provide the 10th prescription that the patient lost, they will at least dose the patient so the patient remains safe. And again, for us, I just want to back up for a second. Remember that when you're providing buprenorphine in the field to this patient who's overdosed and you're giving 24 milligrams, whatever else happens in the 24 to 36 hours after that, that patient is protected from another overdose, right? Because now those receptors are blocked. And so keeping that in mind as you're moving forward, and it allows them a little bit more clarity for 24 to 36 hours because they're not actively trying to score a drug and keep their withdrawal at bay. So that's the first thing. We had the ED. The second thing is that we have an EMS system that is 100% run by our healthcare system. So we're able to review charts, we're able to do education, we're able to set the tone, we're able to get out there. They bring most of those patients to us. In Camden, there are 2 EDs. There's our large, and then there's one that is much smaller community. And the paramedics very actively tried, if they are bringing these patients in, they will try to bring them to us. And then finally, a very robust addiction medicine division. Again, I showed you earlier all the different things that we do, but we do interact quite a bit with the community and with a lot of our community providers, our community programs, our government officials, law enforcement, and the jail. And so again, having a very strong presence in the community and being able to have all these 3 areas, I think is super helpful and allows you to roll this out. And then I want to show you one other thing that I think is really important, which is that, you know, when we went into this and we decided to do this, we really were focusing primarily on patient care and outcomes, because we were also disturbed by the high overdose mortality, the lack of access to care, the lack of access to MOUD. But what we actually found is, yes, absolutely, 44% show up rate, patients were doing better, et cetera. But the silver lining was actually that our EMS this really changed their work, and it changed their satisfaction, and it really decreased their burnout, and they became excited. Now, yes, some of this was our ALS, our paramedic providers, but so many of our other providers, our EMTs, were actively engaging patients. And I remember distinctly after we rolled all this out, talking to one of our EMTs, again, not a paramedic, right? So not administering buprenorphine, but this EMT was talking to me about how, you know, he was in this house with this guy that had overdosed, and he really just, this wasn't the day, the patient didn't want to come in. And he's like, yeah, you know, I just told him, it's okay, like, we're here whenever you are ready and willing. And he's like, it's okay, like, that didn't go well, but that's okay. Tomorrow's another day, and I'll just keep engaging him. And I honestly would have never heard that a year before, 2 years before that, right? So the entire paradigm had kind of shifted to where they saw themselves as agents of change and agents of engagement. So yes, you have this buprenorphine program where we're administering it, we're getting patients on medication, but you parallel to that, you also have a team of EMS providers that see themselves as those agents. They see themselves as those engaging, those interacting, and those able to help patients make a difference. And I think that ultimately was what was so incredibly uplifting, that we were able to elicit that kind of change. And I want to show you guys a quick video. And I will just say that this is a short video that we made, just having our paramedics talk, and it's not very long, I promise, it's like 90 seconds, but it's our paramedics just talking a little bit about the impact that this has had on them. And I kind of want you to hear it from them, because I can sit here all the time and tell you how amazing this is. But I think it's really important to hear from them.
In the early days of my career, I very much, like most of my colleagues, looked at overdoses as a nuisance.
Waking up the same patients with Narcan over and over and seeing them just be in withdrawal kind of made us feel like we were a little bit helpless as paramedics.
We're repetitively treating the same overdose cases over and over, same people, give them Narcan, see them on their way.
It makes you feel burnt out. You just, it gets old, it gets routine. It makes you really not want to give your all.
After we started doing the Suboxone program in the city here, everything changed.
Since we've started administering the buprenorphine in the field, I have a whole new outlook about my job every day.
Now, being able to treat the patients with their withdrawal and actually having a conversation with them gives you a sense that you're actually really helping somebody and that you're making a difference.
It's actually helping me as a provider improve my interactions with everybody, not just patients suffering from opioid use disorder. It's actually helping me grow and better myself.
It allows us to become more involved with the community and be more of a solution to the problem that's been getting worse and worse over time.
appreciate the opportunity to be able to participate in this program and to truly touch lives.
One of the main reasons I stay working at Camden is because I absolutely love what we're able to do right now.
All right. And so, I mean, that's pretty much it. I'm happy to take questions. I did put my email up there. I respond fairly well to email. And I'm more than willing to, answer any questions and, make sure I go over anything that I may not have gone over that I can answer. Any questions, any ideas, any thoughts? Somebody just asked, is there a physician on each ambulance full-time? Oh, goodness, no. No, not at all. So the way it works is we obviously have EMS services 24 hours a day at any given. So ALS is 1 through 5. ALS, and by the way, when we first started, we did a graded introduction. So at first it was just ALS 5. So we trained the 5 or 6 medics that covered that ambulance. They were the ones that went to the clinic first, and it was just one ambulance. And also they didn't prioritize that ambulance going to overdoses. It was just, if they went to an overdose, this was gonna be one of the pathways they could do. Then slowly we brought in one ambulance after the other until all 5 are able to offer buprenorphine. Our physicians ride with the medics during the week on and off. They also, if they're in the vicinity and they hear, listen, if they're in the vicinity and there's a pediatric cardiac arrest, somebody just tries to join, because those are really tough. But no, they don't go out all the time. They just, go out as needed. They do ride also because of quality, et cetera. And also because we have EMS fellows and they ride out there and they're fully trained ER docs, so they can address addiction. So no, so the question is, okay, great. So there's a couple questions. The first is, how did you deal with the ED docs who were hesitant to prescribe? So I get asked this all the time. So a couple different things. One, we had training early on, and the training was done by us. So you had ED docs that were already had their own paradigm shift, right? And remember, ED docs are weird. Like, you want ED docs to talk to ED docs. You don't want anybody else coming in and telling ED docs what to do, because they're not going to listen. And the other thing is that our chair mandated it. He was like, I'm sorry, if you have to learn how to treat a stroke, you have to learn how to treat this. So everybody has to go to the training and everybody has to get their X waiver. And then what we did is we did a lot of elbow to elbow support. So we were available 24 hours a day via phone. And we spent a lot of time, like myself and the other physician were both ER docs. So we spent a lot of time in the ER. And we trained the residents. Here's the other thing. If you have residents, we trained the residents, and our residents were mandated to have their X waiver when they graduated. So you couldn't finish our program without having an X waiver. So it had to be bottom up, top down. And that's sort of, but I actually spend quite a bit of my time. I help other organizations and I lecture across the country and I work with ASAP and I do a lot of things to try to get ED docs to do this work. Now, another question was, do they have appointment dates? Yes. So they cannot leave behind buprenorphine. Listen, we just passed a law that they could leave behind naloxone, right? We're a little bit, again, it's all has to do with legislation. And so they don't leave behind buprenorphine, but they get 24 milligrams, which will last them 24 hours. And then they get an appointment time for the very next day. And if it's in the morning, they can actually come to we have a walk-in clinic every single day, Monday through Friday. So talk about low barrier, and actually I'm working there this afternoon. So you can just walk in and you will see a provider and you will get buprenorphine. So that's what we did. Now on the weekends, it gets a little bit dicier because we aren't open on the weekends, but we just send them to the ED. And we're like, listen, go to the ED. They'll give you a script or they will dose you whatever you want. And the ED does it. They don't turn anyone away. How did you gain your state medical advisor's support? Are you talking about the health commissioner? So if it's the health commissioner, yeah, we basically used all the channels we could. And because of our addiction work and because we were already working on different projects with our Department for Mental Health and Addiction Services, our Department of Health, we were able to get their ear. And also because we had gotten that grant, and so there was a lot of stuff going on, and luckily they listened, and luckily they recognized the incredible potential there. Do we know our retention rates? So our retention rates are actually not different than our regular retention rates, which is around 40 to 60% in our clinic. So once they get into our clinic, they stick around at the same rate as our other patients. How do you get around CASPR reporting for individuals without ideas? I don't know what CASPR reporting is.
CASPR reporting, it's specific to Kentucky. It's like I think it's correct me if I'm wrong, I believe, Jordan, right?
Yeah, I can step in. It is our state prescription drug monitoring system. So any prescriptions that are generated have to be reported to our monitoring system.
Oh yeah, PDMPs. Yeah, we have that for us. Yeah. I mean, our patients have names. So in the field, they're not getting a prescription. So they only get a dose, right? And you don't have to report a dose. EMS doesn't have to report a dose in the PDMP, only a prescription. And the prescriptions are generated by the ED. And when they go to the ED, they register as patients. I will tell you, we are a lot, we work very closely. So the biggest problem we have with identifications is our OTP, right? Because the OTP, because it's federally regulated, is a lot stricter. However, we create IDs through the hospital. So we actually have a hospital system where we will take their picture, generate a sheet with their name and date of birth, and the OTP accepts that. And multiple OTPs across the country are doing that so that they, to help create lower barrier care for these patients. What percentage of consumers do you see in the walk-in clinic that you think are only getting dosed until they can get money to use opioids? And do you even care if it's still harm reduction, at least for 24 hours? Yes, every minute that they're alive is a harm reduction minute for us. I don't know what's going to happen with a patient in 24 hours. I don't know what's going to happen with them in an hour. All I know is right in that moment, I have to give them that opportunity. I can tell you, I have many patients who, they try, it's not working, they overdose again, they go to jail, and then a year later I see them and something clicked, something worked. But if they're dead, like you can never even get to that moment. So our job is to keep them alive. And if that means giving them prescription after prescription, I give them prescription after prescription. Obviously, if it's never in their urine, at some point we have to refer to a higher level of care, right? However, we don't have 3 strikes and are out. As a matter of fact, the only way to ever get kicked out of our clinic is if you are violent or you threaten violence. You can just keep coming. I may not be able to prescribe if it's never in your urine, but I will see you and I will continue to engage with you. Thank you. Yes, Again, I'm going to be very honest. I'm an ER doc, so I did not come to this automatically. Like, I remember in the beginning being like, whatever, they're all going to just sell it. They're all just going to sell it to get dropped, right? That was my mentality. And it took me a while to really kind of change the way I approach this and to realize, like, we don't do this with any other patient. Like, I have patients that come in with DKA and diabetes week after week after week because they're not taking their medication. I don't ever say to them, you know what? You're not taking it. I'm not giving it to you. Of course not. These are medical, we know. And this is a medical problem where literally your brain is and your decision-making is off. So that's the very patient that I can't expect to make good decisions because their decision-making abilities are off. So I just have to keep trying to engage, safe places, trauma-informed care, and creating a kind, supportive, evidence-based place for them to get care.